From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Well, welcome to JAMA Cardiology podcast. My name is Dr. Sharlene Day. I am a professor at the University of Pennsylvania, and I'm associate editor for translational science for JAMA Cardiology. I'm very delighted today to be joined by two astute guests. First is Leonoor Wijdeveld, who also goes by Leo. She is an MD PhD student at Amsterdam UMC and is currently affiliated with the Cardiovascular Disease Initiative at the Broad Institute of MIT and Harvard. We're also joined today by Dr. Jurgens. He is an assistant professor at Amsterdam UMC and also affiliated with the Broad Institute currently. The title of their manuscript that we'll be discussing today is Cardiomyopathy-Associated Gene Variants in Atrial Fibrillation. Welcome, Leo and Sean.
Thank you.
It would be great if you could just start by describing briefly the overall study design and the major findings of your manuscript.
Well, thanks, Sharlene. So we are interested in the value of genetic testing in young people with atrial fibrillation. I'll just say AF from now for short, if that's all right. So especially since genetic testing in young people with AF recently received a 2B recommendation in the EC guidelines this summer. In a specific study, we looked at the prevalence of cardiomyopathy-associated gene variants in people with atrial fibrillation and looked at if carrying a variant, what this means for your risk of future cardiomyopathy or heart failure. So we did this by looking at two large cohort studies, well known to some, the UK Biobank and the All of Us research program, which included over 44,000 people with atrial fibrillation. And here we found that these rare cardiomyopathy-associated variants were actually twice as likely in people with atrial fibrillation and even up to 5 times as likely in people with early-onset AF before age 45. So that's quite a lot. Whilst we already know that people with atrial fibrillation have a higher risk of heart failure, carrying such a gene is actually associated with an even higher risk of developing future cardiomyopathy or heart failure, about 50 to 70% more compared to non-carriers. So we pose that genetic testing for these variants could be positive in quite a substantial amount of people with early onset AF and could stratify individuals at higher risk of heart failure.
I was really intrigued by the fact that atrial fibrillation preceded the diagnosis of cardiomyopathy. Has this been found in other studies? And do you think that it's likely that the cardiomyopathy may be already sort of brewing? In other words, there's some adverse remodeling going on that's just been unrecognized at the time that someone develops atrial fibrillation? Or do you think it's atrial remodeling specifically that kind of precedes the ventricular remodeling? How do you think about that?
Well, let's start at the beginning that there's also a lot of people that had heart failure or cardiomyopathy first and then develop atrial fibrillation. But of course, in kind of this idea where you're trying to maybe do something about developing heart failure, that group is less interesting to us. So in the study, we looked at both of these cases of having already prevalent heart failure, seeing how many CMP variants there are, and then having AF and then developing heart failure. So in both of these groups, it's always kind of one after the other, AF and heart failure. But just for this study, we looked at people that developed atrial fibrillation, and then subsequently potentially developed cardiomyopathy or heart failure. And then secondly, it's about if this is brewing or not under the surface. There's kind of two parts about this, because of course, in a sense, it could already be remodeling. There's remodeling involved in both AF pathophysiology and in cardiomyopathies. But the question if that is clinically already coming out on the surface. And then the second one is kind of if we are detecting that well. So potentially these people could have been diagnosed with a cardiomyopathy if they were tested for that earlier. And then we didn't detect it by the ICD codes, and it could potentially be in the data. So the first one, it's relatively hard to say if there's already remodeling in the tissue and if this is affecting the clinical presentation. But then secondly, we look at did we detect cardiomyopathy in the data set? So of course, people could have already had heart failure or cardiomyopathy that's not clinically detected, and then they get atrial fibrillation, and then we diagnose it later. So that would be biasing the data. But then we looked at both a starting point of how do people develop heart failure or cardiomyopathy after 1 month of AF diagnosis at a minimum. So we give it 1 month to see if the ICD codes maybe still pop up. If they were in one hospital visit, both got diagnosed with AF and maybe a few days later got the code for heart failure. We filtered that out. And then we did a sensitivity analysis where we gave it at a minimum of 12 months between the diagnosis of AF and the diagnosis of heart failure. So we hope to filter out most of these cases where shortly one is diagnosed after the other.
Yeah, absolutely. I mean, I think that 12-month blanking period really was a significant strength of the manuscript because that reduced the likelihood that you had coincident diagnoses and that the AFib was truly preceding the cardiomyopathy.
Maybe I can give some context there as well. So we know from some very specific cases that AF might really precede and be an indicator of cardiomyopathy. I mean, an example is the Lemonopathies. These have already been known quite strongly in the clinic that they tend to develop atrial arrhythmia or conduction disturbances before they get overt DCM. And often it's a bad sign once they start fibrillating, right? And now I think we've just shown this here across a larger spectrum of different genes because we looked into DCM-associated genes, which also include lemon A, but also mostly titin and a lot of other important DCM genes. Also, for hypertrophic cardiomyopathy, we saw the same kind of pattern. So it's really starting to show us that, like Leo says, maybe something's going on under the hood. It's possible. Is it detected? Well, maybe not as often, right? And perhaps these people have somewhat depression in their ejection fraction or have something going on in terms of some hypertrophic phenotype, but it's not quite reaching any the thresholds for diagnosis, or the physicians are missing it. And I think in this case, well, this is also where genetic testing in some patients might really be useful, because let's say you have a young person with AFib and they don't quite satisfy any criteria for an overt ventricular phenotype or cardiomyopathy. Maybe the genetic testing give you some kind of a clue to what might happen later on. And I think this is what our study is, a very nice starting step to show that this is really the case.
Well, that's great, John. I agree. I want to get back to the gene testing in a minute. And I was hoping you could talk a little bit more about the difference in penetrance of these cardiomyopathy variants in the absence versus the presence of atrial fibrillation, because they were really quite strikingly different. And I think that will lead us to the clinical implications of your findings and the applicability of gene testing for people with AFib. So maybe you can talk a little bit about the difference in penetrance. What I took away from it is that the penetrance was about 10-fold higher of a cardiomyopathy variant in those with atrial fibrillation versus those without. And I feel like that was a really important point, because many prior studies have looked at the overall penetrance, of which the majority of those people probably didn't have atrial fibrillation, right, which is very low. And then other studies have focused on people with atrial fibrillation. But this is really, your study design allowed you to compare and show that the penetrance is so much higher for these cardiomyopathy variants in the presence of atrial fibrillation. I don't know if you had any more comments about that, or whether you can comment on how this information would be used clinically, for example. So if for a patient who comes into a cardiologist's office who has atrial fibrillation at the age of 50, what would you recommend?
I agree. This is a really important finding, because if you go a bit more back in time, a lot of our data that we have on outcomes or penetrance of rare variants is based on this selected group of people who have like a family member who's affected, right? So we're thinking about risk in first degree family members. And penetrance that was reported in these kind of studies is always very high, or at least studies differ. But let's say in HCM, considerable penetrance. A lot of people who would carry the familial variant would go on to develop a disease, right? And then came these population studies, like you say, and suddenly there's like the penetrance is less than 5%, right? People are carrying a cardiomyopathy-associated genetic variant. What is the risk? Well, according to the UK Biobank study, a few percent absolute risk. Well, it's total opposites, right? And now we're kind of learning that these people in the middle, right, like you say. So atrial fibrillation might really be this intermediate state where this person is at, they're really starting to show some signs of this variant having some effect on the heart. And I think what it tells you is if you see a young person in the clinic with AF, well, first of all, it is not a good sign. As you said, the absolute risk of heart failure, cardiomyopathy is already relatively high and substantially elevated in any person with AF at a young age. And that's the first important thing to think about. It's not a benign disease where you only have to treat the ischemic stroke risk, right? There's this heart failure component that really has to be taken into account in all. And then secondly, thinking about these pathogenic variants, turning it around, let's say you identify someone who's a carrier, maybe via secondary findings or by incidental findings or whatever, and they develop AF, these are the patients that you really need to look after, because these will be the ones that will go on to develop heart failure more likely, right?
Right. So, I mean, I think if I remember the numbers correctly, it's about 3% penetrance in individuals who don't have atrial fibrillation and 30% in individuals who do have atrial fibrillation. But those with atrial fibrillation even if they don't have a pathogenic variant, was about 20%. So it seems like somebody walks into your office with at least early onset atrial fibrillation should probably be scrutinized, right, and worked up for cardiomyopathy that's present at the time and then followed longitudinally. And then genetic testing should be considered in the right context. Would you agree with that?
Yeah, I totally agree. Yeah. I mean, maybe Leo, do you want to comment on that? What do you think of that?
Yeah, if anything, the scrutinizing for cardiomyopathy or heart failure should not even just extend to the early onset AF, considering that this analysis particularly looks at kind of the whole population of UK Biobank. And then these people, when they're enrolling, are 40 to 60 years old. So you're already looking at a slightly older population and maybe even catching those very, very early onset AF patients. And then even the patients without the pathogenic variants indeed have a quite high risk of heart failure. So that's already kind of a priori type of thing.
Yeah. When we were discussing your manuscript in our editorial board, one of the editors said, so should we be gene testing everybody with early onset atrial fibrillation? And several of us said yes. But basically, in terms of doing genetic testing, there are potential barriers to doing that. When some of us are at institutions where we have embedded genetic counselors and we have experts in cardiovascular genetics, but many places don't have that. And so there's at least a national shortage in the United States of genetic counselors. I don't know what the situation is in the Netherlands, but I think maybe you can just speak to some of the barriers to widespread genetic testing for patients with early onset atrial fibrillation.
Yeah, well, I suppose, of course, things need to be available and they need to be also affordable, let's say. So, of course, we don't really speak to what would be cost effective. So even if from a scientific standpoint, you would want to test all people, let's say before 45 with atrial fibrillation, you would still have to look at if that is possible within different healthcare systems, whether that is available and affordable to patients. So that's kind of more of a second, rather bureaucratic step, I suppose. Sean, do you have any thoughts?
Yeah, I mean, this is a very difficult problem. And I think this is why it's so important that we do the right stratification. I think, Sharlene, you're already alluding to, because we can't offer it to everyone, right? I think we are, at least in Holland, we are quite privileged because you have quite a lot of resources actually to do it, but it's not such a big country, definitely not like the States. I mean, in the States, outside of the big cities, the utility or the use of genetic testing, the breadth of it is much smaller than in the more privileged centers, let's say. So it is a huge issue. And I think it's not something that we'll solve overnight. I think one thing that's good to see is that the prices, at least on the technological side, are dropping. I mean, one issue is just sequencing cost. I don't even know what it costs in the States. Probably to order genetic testing is several thousands of dollars, maybe more. And at least the actual cost of sequencing should be going down to only a few hundred. What that does to the actual cost in practice and to health insurance, I can't comment on that, but hopefully that will be something that improves. And then I guess we will need, especially with this more broad genomic future, we will need more genetic counselors, and we need to also have them in places further away from the specialty centers, right? We need to improve genomic literacy further away from the tertiary center. And this is also something that won't change overnight, but it will be necessary if you want to make the genetic testing, but also the interpretation available outside of the major centers.
I completely agree with you. I think the issues are cost, insurance coverage, familiarity across the country, but also throughout the world with cardiovascular genetics, expertise, both to order the right test in the right person and also to interpret it correctly. And certainly variants of uncertain significance can confuse a lot of people if they're not familiar, right? And so there are still a lot of barriers, but I think that in the ideal world, we're all on the same page that the genetic testing should be performed in individuals with early onset atrial fibrillation, and it benefits their family members in terms of cascade screening as well. I'm just going to ask if either of you have any final comments as we wrap up.
Yeah, so I had a small comment, I think, on the previous question or addition, is that at least we might make a small step kind of improving what the cost would potentially be by saying already going from over 100 genes tested in previous papers on this topic. So the panels were rather large, where here we tried to get only 26 genes to kind of make up this cardiomyopathy panel. And then that also helps with counseling potentially, because these are quite high confidence pathogenic or likely pathogenic variants. And then having, let's say, this large population-based evidence, I hope that will make counseling easier than with variants of unknown significance.
Great. I totally agree. That was definitely a strength of your paper, that it made it very clinically applicable. So I think with that, it will be time to close. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.